So let's go ahead and get started. We have a lot of information to cover today. Welcome to the Society of Thoracic Surgeons, the Congenital Heart Surgery Database monthly webinar. Today is Tuesday, April the 12th. So I was off yesterday, so I had to think about that for a second. So welcome everyone for joining today. Let's see here on the call from the STS side, we have myself and Carol. We have Dr. Meyer joining us. We also have Addie Dolan, Chastity, Emily, Dr. Jacobs, as well as Dr. Subramanian and Melinda. From our IQVIA side, let's see here. We have Joe and Case, Marjorie, and Melanie, and Steve. So thanks everyone for joining today. Be sure to please submit your questions via the Q&A. I think Carol has shut down the chat for now, but again, please be sure to submit your questions via the Q&A. Also, the raised hand function is enabled if you need to, if you would like to just ask your question or if you need to clarify anything. Again, please be sure to use that raise hand function and mute yourself when asked. So for today, I'll just provide a brief STS update, and then we'll turn things over to Chastity for our STS education. Following Chastity, we'll have our IQVIA update, and then as usual, we'll finish things off with your Q&A, your user feedback. If you have any questions about tickets that have been submitted to the help desk, please be sure to include your ticket number. So Steve and team and Michelle, they can start looking into your question while the webinar is continuing. So let's go ahead and hop in with our STS updates. The April training manual has been posted, so that is out there for your review. 2021 harvest update. These next few updates you all should be aware of, but I just wanted to reiterate them. The 2021 harvest update analysis results are of course expected to be available at the end of April. You all will receive an official STS notification when those results are available to you. The spring 22 harvest, as you're aware, the harvest close has been delayed. It was pushed back to Monday, May the 16th at 11:59 p.m. Eastern. That is the last time to get your file in for the spring 22 harvest. And the opt-out date is scheduled for Wednesday, May the 18th. And again, just the spring 22 harvest close was delayed, pushed back due to the delay in getting those 2021 harvest results back to you. Data version upgrade. The official communication was sent on April the 1st announcing that the go live has been delayed until January 1, 2023. So again, that official communication was sent April the 1st. Also, as you are aware, the IQVIA primary procedure mismatch report as of 426, I'm sorry, not 426. We haven't even gotten to 426 yet. As of March the 26th, this report now incorporates the updated stat scores as well as the new rules for the Glenn, Hemi-Fontan, the PDR, as well as the Ross procedures. Updated Appendix C was posted out on the STS website, and we also will be posting an Excel version of that document for you all. So that is with the marketing team, and they will get that posted as soon as possible this week. Should be within the next day or two. Again, that Excel version will be posted for you all this week. So that's all that I have from the STS perspective. I'm going to turn things over to Chastity so she can give her education on the new stat score update. So Chastity,
great, thank you. Yours. Okay. So thank you all for attending the webinar today. I know today was supposed to be an upgrade webinar, and we thought it best at STS to flip this to make it the monthly educational webinar since some new things have rolled out and we're getting lots of questions. And so we thought it better to address those questions first rather than make you wait another week to get the educational webinar in. So again, thank you for attending. Of course, these slides, this presentation is recorded, as well as the slides will get posted on the STS website, usually within a week or so of this. So if anyone has missed this, they'll be able to get the slides and the presentation from the website. So today we're going to discuss, again, we're going to revisit the topic of primary procedure determination in a multi-component operation. And because we've had some changes in the database, I think it's important to readdress this topic. And as well as we're going to clarify missing data for when we get our analysis reports resulted to us. So again, we're going to start with the primary procedure determination in a multi-component operation. Next. Okay, so remember from a previous webinar, there was one last year, 6/15/21, where we reviewed how you determine your primary procedure. So if you still have very detailed questions about this, I do urge you to go back and review that previous webinar, because there's a lot of specifics in the slides and in the talk. But remembering back, for those of you who have seen it, there are some factors to consider when we determine the primary procedure in a multi-component operation. And so two of those largest factors that we would consider are the stat scores, as well as any of the exception rules, which really override what has the highest stat score. There is a document out on the STS website, and it's called Primary Procedure, I'm going to blank on the name on it, but it's Primary Diagnosis and Primary Procedure Determination, but it's right on the website. It gets updated periodically, so you can see what I have linked here to this presentation was just updated in March of 2022. So always refer to that document. If we make changes to exception rules or things like that, you will see that this document will be updated. And we, of course, would come back to a webinar such as this to give you that information. So it would never be you led to it blindly. So as I just told you, things that impact your primary procedure determination are stat scores and new exception rules. And recently, within the last few months in the congenital heart surgery database, we've had just that. Stat scores updated and some new exception rules have come out. So again, there is another previous webinar. I think this one is January 18th webinar, where we went over the exception rules and also more in detail about the stat score. So I urge you to go back if you want some more detail on that. But this slide, just in summary, shows that there was a paper published that re-looked at essentially our points of mortality, our outcomes in the database, and the appropriate stat categories and scores. And so those have now been updated. This paper was published last year. This will now be applied in our spring 2022 harvest. This is the surgery dates of January 1, 2018 through December 31st of 2021. So now we have an updated Appendix C. And I believe the new Appendix C is on the STS website. There may be an update coming out soon. Leanne, correct me if I'm wrong. Is that being posted today, or was it posted?
Yeah, so there is an updated Appendix C coming out. It's with marketing, so as soon as they can get it posted, that will be coming this week as well.
Perfect. So those will get posted, so you will see the update. And so again, you can see what's up now is dated 3/1/2022, but again, there'll be a new one posted this week. As far as the exception rules, there were 3 new exception rules included to the existing exception rules in that primary procedure, primary diagnosis determination guideline. And so these are rules 15, 16, and 17, and address when transplants are done with a Glenn or Hemi-Fontan procedure or a pulmonary valve replacement procedure. And then rule 17 is related to Ross procedure. So I urge you to go reference this document. Again, this is the same one referenced on the previous slide where you find these rules. And this is a part of the new exception rules that help you determine what will be the primary procedure. Next slide. So when we look more specifically at Appendix C, what has updated? You're going to notice that there are existing procedures that now have newly assigned a stat mortality category and score. So that means in the previous stat scores, maybe a procedure did not have an assigned stat score, and now it will. And so a procedure like Glenn takedown now has an assigned stat score. You will also see that there are existing procedures that have an increase in their stat mortality category and score. An example of this is our stage 1 hybrid procedure with bilateral PA bands with concomitant use of PGE or a stent. It used to have a stat mortality category and score of 2.6 and 4, and now that's been increased to 4.8 and 5. There are also existing procedures that have an associated decrease in their stat mortality category and score. And so an example of this would be a complete AV canal repair. And it previously had a stat mortality score and category of 0.8 and 3, and it's now decreased to 0.4 and 2. So these are the anticipated changes that you're going to see in the new Appendix C. So here is just a quick picture of what is posted today on the STS website now. What you see in the white columns that I have the blue arrows facing is the previous stat mortality score and category. So that's what's in white. What is in yellow are the updated stat mortality score and category. And I know because it is labeled as 2020 stat mortality score and 2020 stat mortality category that caused a bit of confusion because they're going live now. And so this is what is being updated this week. They'll still have the yellow columns, which denote the updated score, but it's going to say new stat mortality score and new stat mortality category rather than the year 2020, which was when the paper was completed. And then you're going to see in Appendix C that there are also some blue columns, and these are denoting new fields for the next version. Once called 6.22, but now is going to be called 6.23. So you cannot use these fields do not exist in our current surgical, in our current version. So you can't use these. However, they were updated in Appendix C all at one time. You can't use these until you have a surgery date that occurs on or after the version go live. So that is right now, January 1st of 2023. So you cannot use any of these procedures in blue or purple, whatever color we want to call that, until after that version go live. But they're just in Appendix C because we already determined what their stat scores are going to be. Next. Okay, a few notes about your vendors. So some of you have come back with questions to us that when you are rearranging your procedures and things to follow the new stat scores or new primary procedure determination rules, that it looks strange in your software. And that's because the vendors are not required to maintain stat scores within your software. However, some do, and that's really great, except that they're also then not required to update the stat scores that they do have between data versions. So any changes to your local software will not come from IQVIA and will not come from STS. This is something that would have to come from your software vendor. So I urge you to talk to the representatives from your vendors to find out what they're going to do with the update in stat scores. Next. So as you all know, there's a tool available out on IQVIA's website for us to use, and it's called the Primary Procedure Mismatch Report. It has been updated to follow now our new rules. So just in summary, this report identifies if you've entered your primary procedure following the STS rules for identifying the said procedure. It's recommended that you update your procedures to match what the report is telling you is the primary procedure. And the rules may change over time. And so this report changes over time. And bingo, this is exactly what's just happened. We have a whole change in our stat scores, as well as added 3 new primary procedure determination rules. So what is then in your primary procedure mismatch report is going to change. So when we look at these updates, you are going to have new mismatches for previous surgery years. And of course, we're coming up on a 4-year harvest. These new changes will impact all of your operations within that 4-year data file. So you will see perhaps a large number of mismatches that you now have that you didn't have previously. So this is anticipated. We do recommend that you update your primary procedure mismatches, and you can again refer to Appendix C and all of your resources to find out why something has changed that previously was not a mismatch. So in the future, we know we have a data version upgrade coming, and so we can anticipate that once again, your primary procedure report may have some changes. I think the changes moving forward will be less than the changes now because of the big stat score update. But remember, we're going to have, I believe it's 34 new combination procedures that come out in version 6.23. And so again, we may have to reorder our operations. So more to come as we get closer to go live with 6.23, and we'll do more webinars to discuss this. So I really want to focus more on today what your mismatches may look like. Okay, so let's go through a few scenarios. I'm receiving lots of questions per day about the new primary procedure mismatch report, and I know that there are also some questions going on amongst the Eddie call listserv, and so I just kind of batched these together to try to help address some of these questions. So I now have 50 primary procedure mismatches in the primary procedure mismatch report. Can this be true? And the answer is yes. But the number of mismatches is really going to depend on the procedures that were completed in combination at your center. So whether you're a large volume program or a small volume program, it won't matter. It really depends on the procedures that were done together during one operative setting. So I'm a large volume program, and I also did some beta testing for the new primary procedure mismatch report. And so out of, say, about 2,000 procedures over 4 years, I had about 65 mismatches. And so it didn't take me an enormous amount of time. I was beta testing, so probably longer than it may take you to change those, but I got it done in about 3.5 hours. And I was also beta testing the report, making sure everything was accurate. So I would think that it would take you less time than that. I changed a procedure in a previous harvest, and now it says I have to change it again. How do I handle this? So again, our recommendation would be to go ahead and update your mismatches. But I think it's good to review the reason for the mismatch. Why suddenly do you have a mismatch that you didn't have before? In all likelihood, it's going to be related to either a new exception rule or the update to the stat scores. You want to update the primary procedure in your local software and then resubmit your data file to IQVIA to make sure you clean up that report. My surgeon feels a different procedure is primary than what the primary procedure mismatch report lists. How do I handle this? This is no different than the changes in the prior report. So I think there's some education that needs to happen for the surgeon. They may not understand how we determine primary procedure in the database. And so I would, again, review the rules for determining the primary procedure and diagnosis in the database. Also refer to the new Appendix C. Sometimes if you still can't convince your surgeon, you can always send an FAQ to the core group. We get lots of these. You know, my surgeon feels this way. Can you give me the right answer? And sometimes that's enough to go ahead and convince the surgeon. However, there are some surgeons who still feel they want their local data to be reflective of what they think is the primary procedure. And so just know that on the analysis end, the correct procedure will still be analyzed, but it will not match your local data. And so that's a decision to be made at the local level that your data will not match what your report says. And I don't know about you, that causes me great grief. So I like mine to match, but explaining to your surgeon that your data now won't match what's analyzed. So even though he or she thinks a certain procedure is primary, it's still not going to be analyzed. Sometimes that's enough for a surgeon to say, oh, well, then this is fine. You can still pull out all the procedures that the surgeon has done, whether it's the primary procedure or not, from within your software for local use. And so maybe perhaps, you know, providing that education to the surgeon can be incredibly helpful. How do I verify that the primary procedure report is correct? So again, utilize your resources. And so I keep referring back to the same tables, but I really think that these are exactly what, same reports I should say, but they give you exactly what you need to make this determination. So follow the rules or look at the rules for determining primary procedure and diagnosis. Use your Appendix C, which lists the new stat mortality categories and scores. And you can always send an FAQ to the core group or even a question to me directly. Sometimes it's just you're just not getting it and you just need a quick, this is the reason. Oh yeah, I get it now. And so please, you know, reach out. I urge you to use your resources. The primary procedure mismatch report states a procedure without a stat score is primary. Is this correct? So think back to what has updated. So there are now existing procedures that have been given an associated stat mortality score and category that previously did not have one. But your software may not have your stat mortality scores updated yet. So it looks weird and strange in your software, and it looks strange in my software. So I completely get this headache. It will update eventually, and it will look better, and you'll feel better about it. But right now it's difficult when we're following new rules and our software may have not caught up yet. Next slide. So let's now move to missing data and clarifications for the analysis report. Next. So again, these are some repeated slides from a previous webinar, but just kind of redone for this webinar. But there are some fields that are required for you as a program to be included in the mortality analysis when we get our reports back. If any of these listed fields are missing, your case will be excluded from all mortality analyses. These are all required for the case to be included. So this includes date of admission, a primary diagnosis and primary procedure. And I think I have diagnosis listed twice. I apologize for that. And then mortality status at hospital discharge, your 30-day mortality status, as well as your mortality status at database discharge. So when we look at this first list, if greater than 10% of these are also missing, then the participant file is completely excluded from analysis. On the opposite side, where you have your mortality status at specific time points following the surgery, you'll be excluded if you have greater than 2% missing per analysis year, or really kind of a 12-month period. So we'll go into this a little bit further. Next slide. So remember, we have this mortality eligibility summary report as another IQVIA tool to help us identify our missing. And IQVIA breaks this down by year. And so you can see over on the left, the surgical date range, we have January of 18 to December of 18, and then for 19, 20, and 21. And then you see it'll tell you which cases are ineligible and what your percent missing is. So it identifies the missing thresholds for the participant by your year. And so you can look at this and see, and you want each year to be less than 2%. When you click on the detail for each year or each case, you're able to see, which is what the picture is down below, what is missing from that case that is preventing this case from being eligible or included in the mortality analysis. So you can see from the one example here from mine that I have a 30-day status missing from 2018. It gives me a missing for 1 year of 0.23. So that is less than 2%. And so therefore I would still be, even if I could not find this patient's 30-day status, and I can tell you I cannot, then I would still be included in the mortality analysis. Next slide. So it's important to note that the thresholds for each surgical year in the 4-year analytic window must be met to be included in the mortality or risk adjusted analysis. So remember, the fields are mortality status at database discharge, hospital discharge, and then the 30 days after your surgery. So for this upcoming harvest, where we're going to submit data on May 16th, between 1/1 of 18 to 12/31 of 18, you have to have 2% or less missing or unknown for those 3 mortality fields, as well as for 2019 and 2020 and 2021 to be included in the mortality analysis. Next slide. So just a quick scenario for one of the 12-month periods in the analytic window, I have 2.1% missing. However, my overall missing is less than 2%. Will I still be excluded from the mortality analysis, or will I receive a table 16? And the mortality exclusion answer here is yes, you will be excluded. So the percent missing thresholds must be met for each year within the analytic window. And then again, refer to the analysis overview that's posted in the IQVIA library for more specifics regarding the missing data. And I think that's all I have.
Yes, thank you so much, Chastity. I appreciate it. Next, we'll turn things over to Melanie for IQVIA update. Melanie?
Thanks, Leanne. Can you hear me?
Yes, ma'am.
All right, good.
Sorry.
No problem. Okay, so just to follow back on what Chastity had shared in regards to the primary procedure report, we also wanted to share, and we will post this in the library so that you have reference, but I think visually, we wanted to give some insight on how the report is processing the rules. Of course, you have the documentation that's posted on the STS website, but sometimes we get questions in regards to how certain codes are being handled. And I think this will help. And it's kind of small, but hopefully when we have the posted version, it will, you'll be able to, of course, zoom in on it. But this will allow you to understand the beginning processing stages, and then as it goes through all the way to the end, how the operations and the codes on the operations are being considered. Before I just go do a high-level overview of this, I just wanted to also just state that when you are reviewing the report and you see the suggestions that come back as mismatches, please know that we are not, IQVIA is not changing the code in regards to selecting the primary. It is just displaying as informational. The change would have to happen within your local software, and then you would re-upload that file to basically update the information, and therefore, after the update, it would disappear from the report. Changes that are made during the analysis phase, which is done at DCRI. So I just wanted to make sure that that was clear, that IQVIA is not changing the actual primary procedure. It is just giving the actual, what is intended to be based on the rules, the STS primary. Okay. All right. So just going through the process of this flow, the first thing that the report will do is determine the actual list of the codes that are associated in the operation. So it gathers all of the codes, and then it will determine if there are combination codes in addition to the children codes that belong to the combination. So it goes through and it determines, are there any combinations? And those combinations we call parent codes. And then based on that, are there any child codes in the list? If there are child codes available, basically what will happen is those will be ignored in the determination process. It only will look at the parent code or the combination code when it does the comparisons. And then it moves through the rules. You'll see that there's a transplant rule, and we tried to align the terminology to go with the documentation so that you're able to go through the process and see how the report is making the determination. So it goes through, and if it is an operation that has a transplant, then you would follow the yes path. And then that will just take you down through the determination. And if there is a transplant that is listed on the operation, it would then take the transplant as being the primary. But as it goes through, it determines, okay, no transplants are available on the operation. So we're going to move to the next rule, which is going to be the PSF rule. So then it determines, are there any PSF codes? And so it goes through and it makes that determination, and it looks through different areas of the PSF because there's other codes that have other considerations, right? Other exception considerations. So it goes through that processing and makes that decision. And so again, you can just follow through the flows of the yes path, and then it goes through the Glenn and Hemi codes. So hopefully this will allow you to see how it steps through the actual rules and then comes to the final determination. And again, I want to make sure that you all are able to go through and have a better understanding of how this is happening in the back end, and hopefully this will help. And again, what we'll do is post a version of this for you to be able to look through each of the scenarios that are encountered. The other thing that I wanted to call out is, of course, all of the stat codes have been updated, and that's been posted. So now you'll see a lot of differences that may come back, a lot of mismatches that may come back, just as Chastity had said. And so it is looking at that new implementation, the new code, and making that determination. So I just wanted to also make that clear. I think we had someone that asked the question regarding that, and we've of course gotten a lot of questions related to the codes. So I will again make sure that this is available for you all. And of course, if there's any questions towards the end, we will discuss that. I want to make sure that we leave time for that. So Leanne, let's go ahead and go to the next slide. Also, a quick update in regards to any known issues and updates. Please access the library. We currently have March that's posted. We are working on the April update, so that should be posted by the end of this week. The development team is currently reviewing additional items and just determining whether or not it is an item to be posted. So by the end of this week, we should have an April 2020 version of the document available. And then same slide as before in regards to any submitted tickets, which are currently under review. We are reviewing that, of course, and anything that's being escalated from our support team, we are reviewing within our development team. And they will follow up on any resolutions and when the targeted release, if there's a required targeted release, we would provide that information. And then also any updates we do post to the notification. So please just keep an eye out there. And I think that should be it.
Yes, ma'am. Thank you, Melanie.
Thank you.
All right. And again, just our standard slides. Any analysis report questions, please reach out to tech support, CHSD tech support at IQVIA.com, and then they will forward on to STS DCRI accordingly. So my contact information is listed here. If you have any questions or concerns, reach out to me directly. Here as well, if you have database operational questions, if you have questions about access to the platform, if you have your contact information, access for new contacts to the platform, please email us at stsdb@sts.org. IQVIA tech support is not able to help with that information. So again, if you are updating contacts, you have new contacts or people that require access to the platform, again, reach out to stsdb@sts.org for assistance with your contacts and access to the IQVIA platform. Upcoming webinars, our next monthly webinar is scheduled for May 17th at 12 p.m. Central, and our next upgrade webinar is April 19th at 12 p.m. Central. So mark your calendars accordingly. If you have any questions, again, just please feel free to reach out. That is all that I have for today. I see we have several questions coming in, so let's go ahead and tackle these questions, Chastity and team. Our first question, well, Owen, did you still have your hand raised? I saw your hand was raised earlier, and I don't know if you still, I apologize, if you wanted to make a clarification before we get started. So I'm going to unmute you. But again, I don't know if you.
He said no, it was an accident.
Okay, yeah. Sorry. All right.
Can you hear me okay?
Yes, but hi, Owen. It's nice to hear
Hello.
your voice.
So, no, I was just reiterating what Chastity was stating about not changing your local data, because we've had that from a support perspective quite a few times, where the surgeons say, well, we're not going to change our primary procedure, which is okay. It's just when you run your local data to validate what's reported in the analysis, it will be different because you didn't change your data as requested. So it's okay to keep your data unchanged, but just know that, as it was stated, that DCRI will make the appropriate primary procedure at the data warehouse.
Right.
So if you do nothing. That's all. I just wanted to reiterate what Chastity was saying.
Thank you, Owen.
Thank you, Owen.
Thank you.
Okay, our first question from Angie. Will the report coming out at the end of the month use the new STAT 2020 scores? So the report coming out in fall does not implement the updated 2020 STAT scores. The updated 2020 STAT scores are being implemented as of the spring 22 analysis that we're currently harvesting right now. So just to clarify that, I don't know if anyone has anything they'd like to add to that. Nope. Going once, going twice. Okay.
This is John Meyer. When we do that first reanalysis with the new scoring risk adjustment, in the first report we had talked about having two analyses done from DCRI, one using the old STAT scores and a second and the quote unquote official one using the new STAT scores. Is that still our plan?
I am not aware of that plan. I'm not aware of that plan.
All right. I thought we had talked about that maybe on one of the task force calls. Ram
placed in the chat.
No.
I do not think that is the plan.
Yeah, right.
Okay.
Mm-hmm. All right. Thank you, Dr. Meyer, Dr. Jacobs, Dr. Subramanian. Our next question from Janet. Can you please consider putting the procedure harvest codes in the procedure name section along with the procedure name for the combo procedures? This allows them to be easier to search. Right. I assume you're talking about in the PDF document, Janet, in the Excel.
Is that Appendix C?
Appendix C. So I assume that's what you're asking, Janet. So we can take that feedback back. I did not do that. That's obviously not in the version that's going to be posted earlier this week, but we can take that feedback. back in.
You did clarify, Leanne, in the Excel Appendix C, yes.
Oh, in the Excel Appendix C. Okay. Yeah, we can take that feedback and get that procedure harvest code added to that section. But again, in the one that's going to be posted this week, that's not going to be the case. Marketing already has that for posting purposes. From Jennifer Marietta, why in the world would vendors not update stat scores? Seems so counterproductive. Does anybody know if Lumedics updates them? Jen, I don't know the answer to that question. I would assume so, but I don't know. I believe a majority, most of the vendors do update those stat scores. But again, you would need to reach out to Lumedics. They could let you know directly. I don't know if anyone else.
Yeah, it's never been a requirement for the vendors to do that. So it's up to each individual vendor whether or not they choose to do so.
Correct. From Maori, let's see, I noticed that procedure 1980 sternotomy wound drainage has a new assigned stat score 0.4 category 2 and is taking precedence over other procedures performed during same operation. Example, pacemaker removal. The only thing I can do is confirm that that stat score and category, the updated category is correct. I don't know if any of the surgeons would like to comment there.
Yeah. I guess, is there a question? Is she questioning that?
Yeah.
Well, that is what the stat score is, so that's what the system makes happen.
Right.
I realize that that's not ideal, and it might be something that down the road the task force will need to address with a various rule of some sorts. When we made all the stat scores, we tried to not provide scores for non-cardiac operations. But clearly this is what the score is. That's what's published in the paper, and following the rules as they are now, that's what's going to happen, exactly like Yuri said. So this might be something that Ron might want to take up with the task force in the future to see if we can address that. Or for the time being, that's what the rules are.
Well said, Jeff. I agree completely. I reflect the same opinions as Jeff does. This assignment is commensurate with the currently approved proposal, currently approved practice for assigning primary procedure report. But this is one of a very small number of instances where the intent of the operation is overshadowed by the stat score. And there is a plan for the task force to take up a more comprehensive approach to the primary procedure assignment once the current task force jobs are completed. So we'll definitely look at this as one of the few procedures that require attention, Mayuri. Thank you for bringing it up. And please, if any more comes up like this with any of the data managers, please send this our way so we can have a comprehensive list for the task force to review.
Thank you. And I think Owen, I don't know, Owen, if you had a comment regarding the current discussion. Yes, sir. You should be unmuted.
Yes, thank you. So I just want to reiterate about the stat scores because it is, like Jeff had said, it is not part of the specification. The stat score is an outcome of the analysis that was done by IQVIA and DCRI. So the idea is that vendors would not provide analysis in their software because that would allow the STS to work with DCR and IQVIA to come up with different algorithms where they don't have to tell the vendors those algorithms because that's part of the analysis. So originally the stat scores was not something that's distributed to vendors, and that's why it's more of a value add for any vendor that puts that in their software. So I just wanted to clarify that relationship.
Okay. Thank you, Owen. Okay, next question. Would it make sense to wait until after you get this report back, I'm assuming fall 21 or no, spring 22, to change your primary procedures so they match the report you will get back at the end of this month? Would it make sense to wait until after you get this report back to change your primary procedures so they match the report you will get back at the end of this month?
I think that data is already an analysis, if I'm understanding Janet's correction. So
he's suggesting not to change your primary procedures based on the current mismatches so that your data matches when you get, no?
Yes, Chastity, she said yes.
Okay, so I think that right, you can absolutely do that if you would like, or you can change them now, knowing that when you get your report back, that it may look a little bit different than what your recent data will look like. So I think that you have to come up with a plan yourself as to
I'm
what's
sorry,
the lesser.
Chastity.
Oh yeah.
Which report are we talking about?
The analysis that we should get back at the end of April.
The fall analysis, which that data cut has already happened.
Correct. Yeah. So right now, what's in your local vendor software should match what's coming back from IQVIA at the end of April. But if you start changing your mismatches now, then it will look, your local data will no longer match what's in the analysis ready to come back to you.
Understood.
So Janet is suggesting, do you wait so you can make sure that your data matches when you get the report back in April, but you've got a harvest coming up on May 16th. And so if that's too much crunch time for you, then you may have to live with the mismatches and move forward and go ahead and make the changes in time for May 16th. I think you as a data manager have to determine what's going to be the best for you and your program.
That makes sense.
That makes sense. Yep.
Thank you, Chastity.
Thanks.
Sure.
Thanks, Chastity. Thanks, Janet. Next question for Amy. If the patient does not yet have a date of database discharge date and therefore cannot have a status at database discharge because they have been transferred to a chronic care center, will they count against your 2% missing? Chastity, do you want to answer that one?
Yes, so they will not count against your 2% missing. And there is a way that you leave database discharge. Yep, it's right in the report overview that shows you a table that your mortality status at database discharge versus database discharge date. And so you can see that if you have a database discharge date that is missing, you won't be included or excluded depending on how you have the other fields filled out. And so you see that what Leanne has posted straddles the line. And so if your mortality status at database discharge is missing and your database discharge date is missing, hold on, I got to move this question window so I can continue to see your slide. Will you be counted as missing? No. And so leave your mortality status at database discharge blank and your database discharge date blank, and it will not count as missing. However, if you were to say my mortality status at discharge is alive and things, then you've got some discrepancies within your data. So pay close attention to this table and it will help you, but it will not count against your 2%.
Awesome. Thank you, Chastity. All right. Our next question from Krista. So if I'm understanding correctly, it is optional, not required for sites to make the primary procedure mismatch updates locally, just recommended. Correct.
And just to add to that, again, it's very helpful when you get your report back and it says you have this many stat category 3 mortalities or your length of stay for stat mortality category 3 procedures and things, and you don't have your data to match, you might think there's an error in the analysis report. And so you won't be able to identify that if your data doesn't match. And so it is a really good idea to have your primary procedures match.
Thank you. All right, our next question from Liz. I just want to confirm 1285 aortic arch repair plus VSD went from a stat 4 to stat 2, which is lower stat than 1275 coarch plus VSD stat 3. The aortic arch repair alone is a stat 3. So the 1285 aortic arch repair plus VSD is indeed a 0.4 score category 2. And the 1275 is 0.53. So that is correct. I don't know if any of the surgeons want to comment, but those scores are correct.
I would just comment in that I think that Liz, I think this question comes from Liz. Liz is raising a very good point. And I think the data that's shown there on first blush might seem illogical, But if one goes back to how the stats scores were developed, they were just developed by who lived and who died from operations that are in the database. And it turns out that the risk of dying was higher with aortic arch repair alone than it was with aortic arch repair plus VSD. And that's how those numbers were generated. So those numbers are not generated based on the complexity of the operation or the technical challenge of the operation or how long the operation takes. They're purely generated based on survival in our database. So I think Liz raises a good point because it seems illogical, but that's what it is in the stat scores.
Well, I think the other thing it points out, and as we've already found out, is all of you know that diagnosis, what your underlying diagnosis actually has a significant impact on the outcome from the same procedure. And so, the assumption is that, well, that arch repair is the same when you're doing it for VSD with interrupted arch, as opposed to, maybe an entirely different disease process where there's just an isolated arch repair. So those patient groups are not comparable because they may have different underlying diagnoses. And so I think that's where that's at least one explanation for this apparent discrepancy if we're just thinking about it from the perception or standpoint of the procedure alone without taking into account the diagnosis, because they don't all have the same underlying cardiac anatomy and cardiac diagnoses.
Thank you. And Janet was also pointing out it was the same issue with arch plus switch is less than an arch. I just wanted to recognize that. Another question from Janet, does 1772 conduit placement other have a stat score in new 2020? It says ineligible in the article, but in Appendix C, it carried over the same stat score.
I know that we'd have to look back and see what's in the article.
Yeah.
I know that when we, because I don't obviously know everything on the top of my head, but I know that when the committee that worked on developing these stat scores looked at all of the procedures, we intentionally tried to eliminate any procedure that had the word other in it from being eligible for stat scores, because other could be almost anything. So it wouldn't surprise me that conduit placement other does not have a 2020 stat score. And it might be that Appendix C would need to be updated based on the article.
Okay.
We need to double check. In other words, that we'll need to double check that.
Yeah, I'll double check that, Janet. It may have carried over. Even though it said ineligible, I may have carried it. Okay, I'll follow up with that, Janet. Thank you for pointing that out. Your next question from Brooke. Is the rate of error in the analysis report tracked? How often are there errors? Brooke, are you asking about the rate of error in the feedback reports? I assume. I'm not sure. If you could clarify. But I don't think there's been any official tracking of errors. If you're asking if a report had to be rerun due to an error, I'm not sure. All right, I'm not seeing any additional questions. I don't know, but Brooke, again, I'm not sure has been any official correct rate of error in the harvest analysis feedback report. If there is a discrepancy in what the participant is saying versus what DCRI analyzed. I don't know of any official documentation or tracking of that. Carol, do you have any recollection? I don't know of anything, no.
I think is the primary procedure mismatch report what we're talking about?
Yes, I think if you didn't, what's the error rate if you didn't change your primary procedures to match?
I don't think there's been any official.
Oh no, the actual harvest report.
Can my surgeons give a good definition?
I guess is this the twice yearly report, or I'm sorry, Brooke. Yeah. Is this the twice yearly report or the reports in the participant non-analyzed side?
Twice yearly report, yeah. The actual harvest report. No, we haven't documented, there is no official documentation. We haven't provided that before.
Yeah, I just don't understand the question, Leah. Maybe you should set up a call to talk about it. Sorry.
Yep, sorry, Brooke. Let's see. Can one of the surgeons give a good definition of sternal wound drainage? There's not a definition in the training manual.
Yes, how about I'll add that we have a core group call this afternoon, and we can start that conversation. We can start working on that. It'll take some time to get a consensus definition, but we can work on that.
Yes. Thank you, Joyce. All right. Any additional questions? I don't know if anyone from the call has anything to add while we hold just a minute to see if anything else comes in. Going once, going twice. Maggie, let's see. If a patient is still in the hospital, so doesn't have a discharge date or mortality status, will they be counted in the total number of cases done at our center and included as part of the denominator for mortality calculations?
I think the answer is no. They're completely not analyzed because you don't have discharge date or mortality status filled out at database discharge or hospital discharge for that matter. So the case is not included in the denominators or anything.
You're welcome, Maggie. All right. All right. Any additional questions? We have just a couple of minutes left. Going once, going twice. If you all think of additional questions once we've finished up today's call, please feel free to email me directly. We'll get answers for you. And I agree. Great job, Melanie. The chart is amazing. I agree, Janet. So they did a phenomenal job with that. So that, again, that will be, as Melanie stated, available in the IQVIA library. So I agree, that is a great chart. All right. So see no more questions come in. Thank you everyone for joining the call today. As Chastity stated earlier, this call will be has been recorded and will be posted out on the STS website for anyone to review. Just give us marketing and team a few days to get the video and recording curated and out on the website. So it should be available within, hopefully by the end of the week or first thing next week. So in the meantime, thank you everyone for being on the call today, to our surgeons, to my STS and IQVIA colleagues. Thank you all very much. Hope you guys have a great rest of the day. Thanks everyone.
Thank you, Leanne.
Yeah, thanks everybody. Thank you.
Guys.
Great job. Bye.
Good job, everybody.